Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
The shadow of the COVID-19 pandemic stretches long, doesn't it?
It really does.
For millions of people, the initial recovery wasn't the end of the story. It was the beginning of wrestling with symptoms that just wouldn't go away.
Something scientists are now calling post-COVID syndrome, or, long COVID.
Right.
And when we think of long COVID, maybe fatigue or breathing issues come to mind first.
Yeah, typically.
But what the research really highlights is that one of the most significant and often debilitating areas affected for a huge number of people is the nervous system, the brain, and everything it controls.
Okay, let's unpack this then. Today, we're taking a deep dive specifically into those neurological effects of long COVID.
Yeah.
And this isn't just about feeling a little tired or, occasionally forgetful.
Yeah.
We're talking about impacts that can profoundly change someone's quality of life, their ability to think clearly, to work, to just live day to day.
Our mission for this deep dive is really to give you a clear, fast understanding of this complex topic. We've gone through, a stack of scientific literature, systematic reviews, studies, research papers.
All this stuff.
Exactly. And we're pulling out the most crucial insights. We'll look at what these neurological issues actually are, how common they're turning out to be, who seems to be more susceptible, what scientists think is happening inside the body to cause them, how they're currently diagnosed and managed.
And the long term.
What the long-term picture looks like, and how this is even affecting kids.
Think of it like this. We've got the latest research open right here, and we're exploring it together with you.
Mm-hmm.
I'm bringing the questions and pointing out the interesting facts that jumped out at me from these papers.
And I'll provide the expert analysis, sort of connecting the dots and explaining why it all matters.
Perfect. Consider us your guides on this journey through the data, making sure you walk away with the essential knowledge.
Let's do it.
All right, let's jump right in. To start, how exactly are these persistent symptoms being defined? And what's the scale of this problem globally? I mean, how many people are we actually talking about?
Okay, that first question, the definition, has actually been a bit of a moving target,
Right, I've seen that.
But the core idea across major organizations like the WHO, the CDC, the UK's NICE, it revolves around symptoms that are new or persistent, emerging weeks or months after an initial SARS-CoV-2 infection.
Okay.
They generally require these symptoms to have lasted for at least 3 months or 12 weeks. And importantly, they need to not be explained by an alternative diagnosis.
So it's not just ruling out other illnesses, but acknowledging that the definition itself has been refined over time.
Precisely. And that makes getting precise global numbers tricky because different studies use different criteria, different methods.
Different populations too, right?
Exactly. And looked at varying populations throughout the pandemic as variants in vaccination status changed. So early estimates varied widely.
But a recent major review sheds more light on the overall picture.
Yes. A significant meta-analysis published just this year, January 2025, looked at 144 different studies, and it estimated the global pooled prevalence of long COVID overall at a staggering 36%.
Wait, 36% of everyone infected?
Among individuals who were infected, yes. That's the pooled estimate.
Whoa. That is a massive number, and the sources show a lot of variation.
Significant variation, yeah. That same meta-analysis showed prevalence estimates ranging from around 30% in North America up to like 51% in South America.
Wow.
It illustrates how geography and perhaps other factors play a role. Other estimates break it down by acute severity, maybe 54% in those hospitalized compared to 34% in non-hospitalized individuals.
Okay.
And the WHO has noted that factors like widespread vaccination and maybe the characteristics of newer variants might lead to a lower likelihood of developing long COVID compared to earlier stages.
Which is good news, potentially.
Yeah. Potentially, yes. But even with a lower per-case risk, the sheer number of global infections means millions are still affected. It's still a huge burden.
Okay, so the scale is clearly huge. But why are we putting such a specific focus today on the neurological side of things?
Because the sources are absolutely clear on this. Neurological symptoms are consistently reported as being among the most prevalent and, frankly, the most debilitating aspects of long COVID.
More so than, say, just breathing issues lingering.
They often have a more profound impact on daily function, yeah? They don't just add to the list of symptoms. They often fundamentally impact someone's cognitive function, their energy levels, their ability to sleep, things that underpin daily life, work, learning, social interaction. They are a core part of the syndrome for so many people.
That makes total sense. So who is most likely to face these neurological challenges after COVID? Are there particular risk factors the research points to?
Yes, several factors pop up consistently in the literature. Female sex seems to be one. Older age, and the severity of the initial acute COVID-19 illness, that's a strong predictor.
Hospitalization, ICU.
Exactly. Hospitalization, and especially in ICU, significantly increase the risk. Also, having pre-existing chronic health problems like diabetes, kidney disease, lung conditions, or even prior neurological issues, that raises the risk too.
What about vaccination?
Being unvaccinated against COVID has also been identified as a notable risk factor for long COVID overall. Lifestyle factors like smoking and being overweight or obese are also implicated.
Okay.
And one interesting finding, maybe less known, is that joint hypermobility has been specifically linked to a higher risk of developing autonomic dysfunction, like POTS, in the context of long COVID.
Okay, joint hypermobility, that's interesting. But here's where the research gets really interesting, something that I think fundamentally changes how we should think about this.
Go on.
The sources emphasize that while severe initial illness is a risk, a substantial proportion of individuals develop persistent neurological symptoms even after a mild or even completely asymptomatic initial infection.
This is a truly crucial insight, with major implications. One study highlighted in the sources found that, get this, 75.8% of patients experiencing persistent symptoms that significantly impacted their lives had initial COVID-19 illness that was only asymptomatic or mild.
3/4.
Yes.
Oh.
And they weren't hospitalized. This tells us that the mechanisms driving neurological long COVID aren't just about direct severe damage from the acute phase of infection.
Right. It means the underlying issues could be more subtle, maybe ongoing low-grade inflammation or small amounts of viral components sticking around and causing trouble.
Or the immune system getting confused and attacking the body, or problems with blood vessels, all triggered by even a mild initial infection.
Yeah.
Exactly. And for anyone involved in healthcare or just, understanding the public health picture, this is vital. You need to consider the possibility of neurological long COVID symptoms regardless of how sick someone was initially.
Right.
The pool of potentially affected individuals is just much wider than only those who had severe COVID.
That is both eye-opening and, frankly, a bit concerning. So if the definition is still evolving and it affects even mild cases, what does this wide spectrum of neurological symptoms actually look and feel like for someone?
It's definitely not just one complaint. The sources show that these symptoms often cluster together, which makes sense if they share common underlying mechanisms, right?
Yeah.
You'll frequently see fatigue, cognitive difficulties, and sleep problems presenting together, or maybe dizziness, heart palpitations, and lightheadedness pointing towards autonomic dysfunction.
Ah, okay. Those clusters make sense.
Cognitive issues are also often intertwined with mood disorders, like anxiety or depression.
So they're interconnected issues. Let's dive into some of the most common ones the research describes. Brain fog is probably the one people have heard the most about.
Absolutely, and it's a major feature in the sources. Cognitive dysfunction, or brain fog, it's described as encompassing difficulty concentrating, significant attention problems, issues with memory, particularly short-term and verbal recall.
Remembering words, things like that.
Yeah, exactly. Challenges with executive functions like planning and problem solving, and just a general feeling of slowed mental processing speed. Things just take longer.
And how prevalent is this brain fog?
Well, prevalence estimates vary quite a bit across studies, maybe 30% up to 60% for general cognitive difficulties. Specifically, memory problems are reported around 11%, and that subjective feeling of brain fog is noted in about 32–36% of people with long COVID.
And it can last.
What's striking is that this can persist for 2 years or even longer, according to some data, and its impact on a person's ability to work, study, or simply manage daily life is enormous.
That sounds incredibly disruptive. What other symptoms are commonly reported? Headaches.
Headaches are frequent, yeah, affecting maybe 15% to 25% of people with PCS. They can be persistent or come and go, sometimes feeling like tension headaches or migraines.
New headaches or worse ones?
Can be either new onset or a worsening of prior headaches after COVID. Persistent fatigue is another hallmark, reported in 20% to over 45% of patients.
And this isn't just being tired.
Not at all. It's characterized as a profound, overwhelming tiredness that isn't relieved by rest, and it's very often linked to post-exertional malaise, or PEM.
PEM, explain that again.
That's that significant crash and worsening of symptoms after even minor physical or mental effort. It's a key feature for many. And fatigue frequently appears alongside those cognitive and mood issues.
PM is such a critical concept for understanding this illness, and something we'll definitely revisit when we talk about how to manage it. What about sleep problems?
Sleep disturbances are also highly prevalent, affecting 25% to over 40%. This includes insomnia, sleep that just doesn't feel restorative, even nightmares sometimes.
Wow.
One study mentioned a striking 92% increased risk of developing new insomnia, specifically after COVID infection compared to influenza.
92% increase. That's huge.
It really is. And of course, poor sleep significantly worsens fatigue, cognitive function, and mood. It's all connected.
And those sensory changes people might have had during the acute infection, like losing their sense of smell or taste, do those often stick around?
Yes, they can. Persistent anosmia, or loss of smell, is noted in about 11–12% of people with PCS.
Still can't smell things months later.
Right, and altered taste is juicier in maybe 9–10%. The sources suggest this might be due to ongoing inflammation or difficulty with the nervous system's regeneration in the olfactory pathways. Paresthesia, those tingling or pins and needles sensations, are reported in around 6%.
Okay.
And dizziness or vertigo can also persist, seen in up to a third of patients who also have headaches.
And musculoskeletal pain, that's often reported, but how does that connect to neurology?
Good question. Muscle pain, myalgia in 17–18%, and joint pain, arthralgia, in over 40% are indeed common. The sources point out that these can have neurological connections, potentially stemming from inflammation or maybe nerve involvement related to the broader post-viral processes happening in long COVID.
Interesting. Beyond the more physically perceived symptoms, what about neuropsychiatric effects, the mental health aspect?
Anxiety and depression are highly prevalent. The research shows anxiety maybe 20–30% and depression in 15–28%.
And is that biological or psychological?
It could be both, really. It might be a direct biological consequence of the virus affecting the nervous system, or a very understandable psychological reaction to living with a chronic, often disabling, and frankly, poorly understood illness.
Makes sense.
Post-traumatic stress disorder, or PTSD, is also seen, particularly after severe acute illness requiring hospitalization, affecting about 14–30%.
And a term that comes up often in the sources is dysautonomia, issues with the autonomic nervous system. What does that mean, and how does it present?
Right. Dysautonomia. It refers to dysfunction of the autonomic nervous system. That's the system controlling all the involuntary bodily functions like heart rate, blood pressure, digestion, temperature regulation.
It's stuff you don't think about.
Exactly. Even things like pupil response and sweating. It's increasingly recognized as a significant component of long COVID. POTS, or postural orthostatic tachycardia syndrome, is a specific and common form diagnosed after COVID.
And POTS is characterized by? Remind me.
A sustained significant increase in heart rate, typically 30 beats per minute or more in adults, maybe 40 in adolescents, just upon standing up. Critically, without a significant drop in blood pressure.
Okay. And the symptoms?
Symptoms commonly include dizziness, heart palpitations, lightheadedness, that overwhelming fatigue again, difficulty exercising, and even brain fog seems linked.
So POTS and brain fog can go together?
Yes, they often do. One study cited found that 40.5% of long COVID patients diagnosed with autonomic dysfunction were newly diagnosed with POTS.
So POTS is one specific type of dysautonomia, but there's more.
Yes, exactly. Dysautonomia in long COVID can manifest more broadly. Patients might experience unstable or lay-by blood pressure, persistent digestive issues, difficulty regulating their body temperature, severe exercise intolerance.
A whole range of things.
Yeah. One study using a comprehensive symptom score found that a large majority, 71.9% in a long COVID cohort, had moderate to severe autonomic dysfunction.
Wow. And finally, on the symptom side, the sources mention ocular issues with neurological links, eye problems.
That's right. Because the ACE2 receptor, which the virus uses to infect cells, is present in eye tissues, various eye-related issues have been reported. These can include optic neuritis, inflammation of the optic nerve, Changes in visual acuity, blurred vision,
Light sensitivity.
sensitivity to light, photophobia, and seeing floaters. The research links these potentially to neuroinflammation occurring within the eye itself, affecting the supporting cells and involving immune cell infiltration.
That's an incredibly broad range of symptoms, from cognitive function to heart rate control to vision, all potentially linked to the nervous system. It really underscores the complexity.
It really has.
So let's try to understand the why behind this. What do the sources tell us about the complex pathophysiology? How is the virus potentially causing all these different problems?
This is really the forefront of current research, and the sources emphasize it's not one single cause, but multiple interconnected mechanisms working together. A central player appears to be neuroinflammation.
Inflammation impacting the brain and nervous system.
Exactly. The initial systemic inflammation from the acute COVID infection, often involving a surge of inflammatory molecules called cytokines, things like IL-1, IL-6, TNF-M.
The cytokine storm idea?
Sometimes, yes, or just prolonged inflammation. This can have widespread effects, including reaching the central nervous system. These cytokines can disrupt the blood-brain barrier, that crucial protective shield that normally prevents harmful substances and cells in the bloodstream from getting into the brain.
So a leaky blood-brain barrier, allowing bad stuff in.
Precisely. A compromised barrier allows inflammatory molecules and even peripheral immune cells to cross into the brain tissue. And the research indicates this inflammation isn't necessarily just an acute phase issue.
It sticks around.
There seems to be persistent activation of the brain's own immune cells, called microglia and astrocytes, particularly in areas important for cognition and motor function, like white matter and the hippocampus. And this happens even after mild initial COVID.
Okay. And what do those activated brain immune cells do?
Well, they can become neurotoxic. They can release substances that are harmful to neurons, disrupt the myelin sheath that insulates nerve fibers, and impair the creation of new neurons, neurogenesis, in areas like the hippocampus, which is vital for memory.
Okay, so persistent neuroinflammation is a big piece. What about the virus itself? Is it hiding or lingering in the nervous system?
The role of direct viral persistence is still a subject of intense debate and research, but there is evidence for it. Sources mention detecting SARS-CoV-2 RNA, proteins like the spike protein, and sometimes even what looks like viral particles in some brain tissue samples, cerebrospinal fluid or eye tissue, months after the initial infection.
Months later. Wow. How does it get in?
Potential ways the virus might get in include through the olfactory nerve from the nose, perhaps the vagus nerve, or by crossing that leaky blood-brain barrier from the bloodstream.
And that spike protein itself might be causing trouble, even if the virus isn't actively replicating.
Yes, there's a hypothesis that the viral spike protein, even if it's just fragments sticking around, could be directly neurotoxic. It might activate those microglial cells we talked about, disrupt communication between neurons, and impair neurogenesis.
So persistent viral bits could keep the immune system fired up.
Exactly. If viral components persist, even at low levels, they could continuously stimulate the immune system, contributing to chronic inflammation and dysfunction.
What are some of the other proposed mechanisms? Autoimmunity seems relevant here.
Absolutely. The sources strongly suggest that for many people with long COVID, the immune system mistakenly turns on the body's own tissues, including components of the nervous system.
How does that happen?
It could happen through something called molecular mimicry, where viral proteins look so similar to proteins in our own cells that antibodies or T cells generated to fight the virus end up attacking our own tissues by mistake.
Attacking nerves, potentially.
Yes. This process can target neural antigens, or certain cell receptors, which might contribute to things like the dysautonomia we discussed, especially POTS. Evidence of immune dysregulation, changes in the function of T and B cells, is also reported. These autoimmune attacks contribute to inflammation, potential nerve damage like demyelination, and widespread dysfunction.
And blood vessel problems. You mentioned the blood-brain barrier.
Yes, endothelial dysfunction, damage to the cells lining blood vessels, and microvascular injury are considered key contributors. The virus can directly infect these endothelial cells throughout the body, including in the brain.
And that damages the vessels.
It damages the vessels, yeah.
Yeah.
Leading to impaired blood flow, sometimes the formation of tiny blood clots or microthrombosis, and contributing to that critically important leaky blood-brain barrier.
So vessel damage makes the inflammation worse, creating a cycle.
Exactly. A leaky barrier lets more inflammatory molecules and immune cells into the brain. Compounding this, the specific pattern of cytokines seen in COVID-19 seems to particularly promote BBB disruption. The consequences are reduced blood flow to parts of the brain, potentially leading to periods of low oxygen or ischemia and amplified neuroinflammation. It feeds itself.
Fatigue is so dominant in these descriptions. Is there a biological explanation emerging for that specific symptom?
That's where mitochondrial dysfunction comes in. Mitochondria are essentially the powerhouses of our cells, right? They generate energy.
Yeah, cell battery.
Exactly. Research suggests SARS-CoV-2 might impair mitochondrial function, especially in cells that need a lot of energy, like neurons. This leads to energy deficits, increased oxidative stress, and also contributes to the inflammatory state. This mechanism is thought to directly link to profound symptoms like that overwhelming fatigue and brain fog.
And the support cells in the brain, the glial cells, they're affected too.
They are critical. Glial cells, astrocytes, microglia, oligodendrocytes, they're vital for supporting neuron health, maintaining the environment, forming the myelin sheath around nerves.
Oh, they do a lot.
A huge amount. When these cells become dysregulated, maybe by inflammation or direct viral effects, they can stop being supportive and actually become harmful. This disrupts their ability to nurture neurons, damages myelin, which slows down nerve signals, and alters how neural circuits function and adapt things like synaptic plasticity, essential for learning and memory.
So the brain's wiring and support system gets disrupted.
Right. This widespread disruption contributes to cognitive problems, fatigue, and many other neurological symptoms. Sources note findings like a reduction in oligodendrocytes and myelinated nerve fibers in some cases.
So it's less one big hit and more a complex web of interacting problems, a cascade almost.
Precisely. And these mechanisms can create vicious cycles. A leaky blood-brain barrier fuels inflammation, which further damages the barrier and activates more glial cells, perpetuating the inflammatory state. Ongoing immune responses, possibly triggered by lingering viral components or autoimmunity, add to this cycle. This interconnectedness and the potential for self-reinforcement are key to understanding why these symptoms can become chronic and persistent.
And I suppose in severe acute cases, things like low oxygen during the illness just add another layer of damage on top of all these other mechanisms.
Yes, absolutely. Conditions during severe acute COVID like hypoxemia, low oxygen, hypotension, low blood pressure, and metabolic disturbances can cause direct injury to neurons, compounding the effects of the subsequent PCS mechanisms.
And maybe reactivating old viruses.
That's another hypothesis. Reactivation of latent viruses like EBV, Epstein-Barr virus, HHV6, CMV, potentially triggered by the immune disruption caused by SARS-CoV-2, has also been proposed as a potential contributor to symptoms like fatigue and cognitive issues. It's a truly complex puzzle the body is trying to solve, or maybe failing to solve.
With such a complex mix of potential causes and such a wide array of symptoms, how is neurological long COVID actually diagnosed? It sounds incredibly difficult if there's no single test to confirm it.
You've hit on one of the biggest challenges, yeah. Both for patients and clinicians, the sources are very clear. There is currently no single definitive test for neurological long COVID.
No blood test, no scan.
Not definitively, no. The diagnosis relies heavily on a detailed and careful clinical history. That means establishing that there was a prior SARS-CoV-2 infection, confirming the persistence of symptoms for the defined time frame like those 3 months or 12 weeks we talked about, and crucially, performing a thorough workup to exclude other medical conditions that could be causing similar symptoms.
So ruling other things out is key.
It's essential. And the patient's story, how they're feeling and what they're experiencing, is absolutely paramount.
Why is the history so critical?
Because the symptoms are incredibly varied, often nonspecific. They can fluctuate significantly day to day or week to week, and patients often describe it as an invisible illness that is difficult to articulate or for others to fully grasp.
Yeah, that invisible part must be so frustrating.
Exactly. The sources really emphasize the need for empathetic communication from healthcare providers, validating the patient's reported experience, and taking the time to deeply explore the timeline, nature, and impact of their symptoms on their life. And the fact that definitions have evolved also adds complexity here.
What about objective tools? Are there questionnaires or tests to quantify things, put numbers on it?
Yes, clinicians do use validated questionnaires and scales to try and quantify symptom severity and impact. These include specific scales for fatigue, like the MFI-20 or FAS, sleep quality, the PSQI, mood, like HADS, autonomic symptoms, Compass 31, and overall quality of life, NeuroQOL.
Okay. And for cognition?
For cognitive assessment, neuropsychological testing is important. Screening tools like the MoCA or MMSE are often used first. The MoCA is generally seen as more sensitive for milder cognitive impairment.
And if more detail is needed?
If indicated, More comprehensive batteries of tests evaluate specific cognitive domains like memory, attention span, processing speed, and executive functions tests like the trail-making test or the Ray-Ostrieff complex figure test.
And a standard checkup.
Oh yeah, a standard neurological examination is always part of the process to look for any focal deficits or signs of other neurological diseases. And routine lab work is also standard practice to rule out common reversible causes of symptoms like thyroid issues or vitamin B12 deficiency, things like that.
What about brain imaging, like MRI scans? Do those typically show clear evidence of long COVID? People often ask for scans.
Right, neuroimaging is complicated in this context. It's used extensively in research, of course, and clinically primarily to rule out other conditions like a stroke or a tumor or other structural brain lesions.
But does it show long COVID?
Standard structural MRI findings in long COVID have been quite variable. Some studies report decreases in gray matter volume or cortical thickness in certain areas. Others report increases in thickness, and some find no significant change at all compared to controls. Increased white matter lesions, like little spots, have been observed in some studies, sometimes linked to headaches. So there isn't a consistent diagnostic structural MRI pattern for long COVID that jumps out.
So a normal MRI doesn't mean someone doesn't have neurological long COVID.
Exactly. That's a really important point.
Yeah.
What about more advanced imaging techniques? Are they more revealing?
Techniques like diffusion tensor imaging, DTI, which looks at the integrity of white matter, tracks the brain's wiring,
Yeah.
have sometimes found reduced coherence, lower fractional anisotropy, potentially indicating microscopic structural changes. And these findings sometimes correlate with subjective cognitive complaints, the brain fog people feel.
Okay, so maybe subtle changes in the wiring.
Possibly. And functional MRI, fMRI, which measures brain activity, has shown altered connectivity patterns when the brain is just at rest. And during cognitive tasks, fMRI often reveals atypical patterns of activation,
What do you mean by atypical?
frequently showing higher or more widespread brain activity compared to healthy individuals doing the same task. That's interesting, the brain working harder to do the same thing.
Potentially, yes. It could suggest that the brain is having to recruit more areas or work less efficiently to accomplish a task that should be relatively easy. Compensation, perhaps, but inefficient.
And PET nor SPECT scans.
PET and SPECT scans, which look at brain metabolism and blood flow, have shown regional areas of reduced metabolism or blood flow that correlate with specific symptoms. For example, hypometabolism in frontal areas linked to executive function difficulties or changes in areas associated with memory or sleep regulation.
Is there any hope for objective biomarkers like a blood test that could definitively say someone has neurological long COVID? That seems like the holy grail.
It really is. The search for reliable biomarkers is a major research priority, and it's promising, but most potential markers are still firmly in the research phase, not ready for routine clinical use yet.
What are they looking at in blood?
Researchers are looking at markers of neuronal injury like NFL and GFAP, which are sometimes elevated in long COVID patients and linked to inflammation or damage. Persistent inflammatory markers like specific cytokines and CRP are also being studied. Autoantibodies targeting various tissues, including neural ones, are a hot area of investigation, as are other plasma markers related to inflammation or cell death, apoptosis.
And looking directly at the fluid surrounding the brain and spinal cord, CSF, that seems more direct.
Cerebrospinal fluid, or CSF analysis, can give a more direct window into the central nervous system, yeah. Studies have found elevated inflammatory cytokines, markers of neuronal injury, and signs of activated immune cells in the CSF of some long COVID patients.
Okay.
What's particularly interesting is that elevated CSF cytokines have been observed even without detecting viral RNA in the CSF.
Ah, so inflammation without active virus in the brain fluid itself.
Exactly, which supports the idea that inflammation can persist in the brain independently of active viral replication in that compartment. The fire keeps burning, so to speak, even if the original spark is gone from there.
Here's something crucial the sources highlight, and it gets at the core of the challenge. Patients often report debilitating symptoms like brain fog, but sometimes their standard objective tests, like routine cognitive assessments or MRIs, come back looking relatively normal.
This disconnect is a huge source of frustration and misunderstanding for both patients and clinicians. It's really tough.
Yeah, I can imagine.
A patient might be profoundly struggling to think or remember, yet perform within the normal range on a standard neuropsychological test, or have a perfectly normal structural MRI.
Which could lead someone to doubt them, unfortunately.
Right. The sources stress emphatically that this doesn't mean the symptoms aren't real or severe. It suggests that our current standard objective tools may not be sensitive enough to capture the subtle, fluctuating, or maybe the effort-dependent nature of these neurological issues. How much harder are they working to get that normal score?
That's a great point.
More sensitive functional imaging like fMRI or maybe future biomarkers might correlate better. But for now, we need better objective measures, and fundamentally, we must value and trust the patient's reported experience as primary evidence.
So for now, neuroimaging and most biomarkers are mainly research tools or used to rule out other conditions, not diagnose long COVID directly.
Exactly. They are promising avenues for research and future diagnoses, but they haven't reached the point of being definitive clinical diagnostic tests for PCS yet.
Okay, so diagnosis is clearly complex and relies heavily on clinical history. What about management and treatment? If there's no single test or single cause, what can actually be done to help people struggling with these neurological issues?
The sources make it very clear that current management is centered around a comprehensive, multidisciplinary, and really patient-centered approach.
Teamwork.
Definitely. The goal is to alleviate symptoms, restore function as much as possible, and improve quality of life. It requires a team of specialists, neurologists, rehabilitation therapists like PT, OT, speech, mental health professionals, and care absolutely must be tailored to the individual patient's specific and often fluctuating symptom profile.
And believing the patient.
And, as we just discussed, validating the patient's experience is crucial, given how invisible and variable these symptoms can be.
So it's about treating the specific symptoms someone is experiencing first and foremost.
Yes, a major part of it is symptomatic management, using existing treatments for similar conditions. This means addressing headaches with appropriate therapies, identifying triggers, improving sleep, sometimes medications, using medications for neuropathic pain if needed, like gabapentinoids or certain antidepressants, focusing heavily on sleep hygiene, sometimes using melatonin or other sleep aids, and employing cognitive behavioral therapy for insomnia, CBTI, which can be very effective.
And mood.
Anxiety and depression are managed with standard therapies, which might include counseling, psychotherapy, or medications like SSRIs or SNRIs.
And rehabilitation seems like a core component you mentioned.
It's described as a cornerstone of management in the sources, absolutely. Cognitive rehabilitation is vital for that brain fog, memory problems, attention deficits, executive dysfunction.
Who does that?
This is typically delivered by speech-language pathologists or neuropsychologists. They use compensatory techniques, teaching strategies to work around deficits and targeted training exercises.
Does it help?
Studies show promise, yeah. Reporting improvements in patients' self-reported cognitive skills and overall quality of life. Though coexisting anxiety can sometimes limit the benefits, it seems, these programs usually involve multiple sessions over weeks or months.
What about physical therapy, especially given the fatigue and that PEM we talked about? That seems tricky.
It is absolutely crucial, but it requires a very careful, very nuanced approach because of post-exertional malaise. This is key.
How so?
Rehabilitation for fatigue and deconditioning must be paced cautiously. Energy conservation strategies are vital, often summarized as the 4 Ps. Pacing your activities throughout the day, planning your energy use ahead of time, prioritizing what's most important to spend energy on, and using good positioning to conserve energy.
Pacing, planning, prioritizing, positioning. Got it.
Any increase in activity must be very gradual and strictly symptom contingent, meaning if activity worsens symptoms significantly, you have to back off immediately.
So no pushing through it.
Absolutely not. The sources explicitly warn that traditional aggressive graded exercise therapy, the push-through-it approach, can actually be harmful for patients who experience significant PE. It can cause major setbacks.
Okay, that's critical. What else does PT help with?
Physical therapy also helps with other issues like balance problems, gait difficulties, and breathing exercises can be useful too.
What other types of rehabilitation are used? Smell training.
Olfactory training, yeah. It's recommended as a first-line treatment for persistent loss of smell. It involves repeated, structured exposure to different odors over time to try and retrain the system.
And speech therapy.
Speech and language therapy can also help with other communication issues like word-finding difficulties that are often part of the cognitive dysfunction picture. And vestibular rehabilitation is the go-to for dizziness, vertigo, and balance issues.
Are there any specific medications that target the underlying causes of neurological long COVID? Or is it all just symptom management?
This is still very much an area of active investigation. And definitive, widely approved therapies specifically for the underlying mechanisms of neurological long COVID are currently limited. It's mostly experimental.
Okay.
Many drugs are being explored, often repurposed drugs, or tested for their potential anti-inflammatory or immunomodulatory effects.
Like what kind of drugs are being looked at?
Well, immunomodulators and anti-inflammatory agents are a big focus. Examples include baricitinib, a JAK inhibitor, which was explored in trials. Short courses of corticosteroids might be considered in certain situations, but long-term use has risks.
Anything else showing promise?
Low-dose naltrexone, LDN, which is thought to modulate the immune system's glial cells, has shown some promising results for fatigue and brain fog in smaller observational studies. But larger, rigorous clinical trials are definitely needed. IVIG, intravenous immunoglobulin, used for some autoimmune conditions, has shown positive effects on fatigue and cognition in small studies. But it's invasive, expensive, and needs much more validation in bigger trials. Statins, commonly used for cholesterol, are also being considered for potential indirect benefits due to their anti-inflammatory properties.
What about antiviral medications like Paxlovid? Could that help after the acute phase?
It's debated. While nirmatrelvir-ritonavir Paxlovid is primarily for acute COVID, extended courses have been studied for long COVID symptoms with kind of mixed trial results so far. There is a suggestion in some data, though, that early antiviral treatment during the acute infection might reduce the subsequent risk of developing long COVID in the first place.
Okay, any others?
Another antiviral, ensitrelvir, in trials didn't show an overall reduction in long COVID incidence, but some participants did report less fatigue and a quicker return to baseline. So the jury's still out on antivirals for established long COVID.
Are any drugs specifically targeting the idea of viral persistence, like that lingering spike protein?
Yes. The sources mention investigative agents like AER002, which is in clinical trials, aiming to neutralize the viral spike protein directly. That's based on the hypothesis that persistent spike protein fragments might be driving symptoms in some people.
What about other potential treatments? Metformin?
Metformin, yeah, the diabetes drug, it actually reduced long COVID incidence in one large trial when given during acute COVID, possibly through anti-inflammatory pathways. Omega-3 fatty acids, L-arginine, which might help endothelial function, NAC and guanfacine are also being explored experimentally for various neurological symptoms, targeting different potential mechanisms.
And it's important to note, as the sources do, that not all trials have been successful, right? Some things haven't worked out.
Absolutely. That's a crucial point. Trials for drugs like temolizumab, aimed at neuropsychiatric symptoms, and BC007, targeting specific autoantibodies linked to POTS, were unfortunately stopped or didn't meet their primary endpoints.
Which shows how hard this is.
It really highlights the difficulty in developing effective therapies and the absolute need for continued rigorous research. Finding the right target for the right patient group is challenging.
So it sounds like current management heavily relies on managing the symptoms and using rehabilitation, while targeted treatments are still largely investigational. What about non-invasive approaches, like stimulating the brain?
Right. Non-invasive brain stimulation techniques are being explored as adjunctive therapies, things you add on. Repetitive transcranial magnetic stimulation, RTMS, which uses magnetic pulses delivered to specific brain areas, has shown some promise in studies.
For what symptoms?
Sometimes improving attention, memory, and mood, especially when combined with cognitive training. Transcranial direct current stimulation, TDCS, using weak electrical currents is also under investigation.
And stimulating the vagus nerve.
Vagus nerve stimulation, VNS, using non-invasive devices usually worn on the ear or neck, is being explored quite actively. Stimulating the vagus nerve can modulate inflammation and autonomic function, so there's hope it might help with fatigue, dysautonomia, and maybe even cognition. Still needs more research, though.
Are there any other more experimental or alternative treatments mentioned, things people might hear about?
Therapeutic apheresis comes up. That's an invasive procedure to filter blood and remove inflammatory substances or autoantibodies. It's being studied but needs much more research to see if it's safe and effective for long COVID. Hyperbaric oxygen therapy, HBOT, breathing pure oxygen under pressure.
Right, I've heard of that.
It has shown some preliminary positive findings in small studies, but expert opinion is mixed. It's costly, not widely available, and not FDA approved for this condition specifically. Acupuncture is also being explored based on traditional Chinese medicine principles.
And lifestyle.
And, of course, general lifestyle interventions, ensuring good nutrition, really strict sleep hygiene, stress management techniques, and maintaining social activity as much as possible. These are always important supportive components of care.
So a landscape of symptomatic treatment, crucial rehabilitation, and a wide array of experimental therapies still in the research pipeline. Given all this, what does the long-term prognosis look like for people with neurological long COVID? How long do these symptoms typically last, and do people recover?
The sources paint a complex picture, definitely variable prognosis. For many, symptoms persist for significant periods, weeks, months, and critically for a substantial subset, for years.
Years.
Yes, reviews confirm symptoms persisting at 1 to 2 years post-infection commonly. One study focused on autonomic dysfunction reported a median symptom duration of 36 months, that's 3 years.
Wow, and it's not always steady improvement.
No, what's also challenging is the often fluctuating course. Symptoms might improve for a while, only to relapse, sometimes triggered by stress, physical or mental overexertion, that PEM again, or unrelated illnesses. It can be a real roller coaster.
Does that mean most people eventually recover completely? Or is it often chronic?
Outcomes are highly variable. Some individuals do experience gradual improvement over time, often within 1 to 2 years, particularly with appropriate management and rehabilitation. They might reach a point where residual symptoms are manageable. They learn to live with them.
But not everyone.
But for others, the symptoms unfortunately remain chronic and disabling. The sources note that we don't yet fully understand why some recover relatively well, while others face chronic disability. It's likely a combination of the specific underlying mechanisms in play for that individual, the severity of their initial acute illness, pre-existing health conditions, access to care, and maybe individual factors like resilience. We just don't know all the predictors yet.
What's the impact on their daily lives during this period, especially if it's chronic?
It is consistently reported as profound. Neurological symptoms like that persistent brain fog, the overwhelming fatigue, ongoing pain, sleep deprivation, and dysautonomia significantly impair a person's ability to perform basic daily activities, to work or attend school, maintain social connections, even manage self-care.
Quality of life takes a huge hit.
A significant reduction in overall quality of life, yeah. Often measured using tools like the EQ-VAS scale, showing much lower scores compared to healthy populations. One study on autonomic dysfunction, for example, found that 37.5% of patients were unable to work or had to drop out of school due to their symptoms.
That's huge.
And the economic impact from lost productivity is also substantial at a societal level.
And there's an emerging concern, a worrying one, that long COVID might increase the risk of future neurodegenerative diseases like Alzheimer's or Parkinson's.
Yes, this is a very serious concern that is highlighted repeatedly in the research and is prompting urgent long-term studies. The worry is whether persistent neurological PCS might increase a person's lifetime risk of developing conditions like Alzheimer's disease, Parkinson's disease, or other dementias, or perhaps accelerate the progression of these conditions if someone already had underlying risk factors.
Why is that concern arising? What's the biological link?
Because there are plausible biological overlaps and shared mechanisms, things like chronic neuroinflammation, persistent microvascular damage, ongoing autoimmune processes, and alterations in protein metabolism like the amyloid beta plaques seen in Alzheimer's. These are implicated in both neurological long COVID pathophysiology and in the development of classical neurodegenerative diseases.
So the damage mechanisms look similar.
Some of them do, yes. There's also a suggested genetic link. The APOE4 allele, a well-known genetic risk factor for Alzheimer's, has also been associated with increased severity of acute COVID. Furthermore, neuroimaging findings in long COVID sometimes point to changes in brain regions, like the hippocampus and areas of the cognitive cortex, that are also affected early in Alzheimer's and other dementias.
So there are solid biological reasons to be worried about this.
Exactly. And initial longitudinal studies following people for a couple of years now have indeed started to report an increased risk of new diagnoses of cognitive impairment, dementia, seizures, and even psychosis persisting for at least 2 years post-infection compared to control groups who didn't have COVID.
Wow, that's sobering.
It is. However, the sources are very clear that while concerning, we need much longer-term, large-scale longitudinal studies following diverse populations for many years, maybe decades, to definitively confirm this potential increased risk and understand how big it might be.
It sounds like the entire experience of having COVID-19 and then long COVID can act as a significant stressor on the body and brain overall, potentially unmasking or accelerating other health issues.
It certainly can. It appears to function as a major systemic stressor that can destabilize pre-existing chronic conditions or reveal latent vulnerabilities that someone wasn't previously aware of. This could potentially lead to the development of new chronic issues beyond the core PCS symptoms themselves, things like new onset diabetes, cardiovascular problems or other neurological conditions popping up later.
Have any studies followed people long enough to see outcomes multiple years out, say 2, 3 years or more?
Data is slowly emerging on longer-term outcomes. That 2-year MRI study we mentioned, while showing variable objective cognitive results, confirmed persistent subjective cognitive symptoms, fatigue, and reduced quality of life. It also found some subtle structural brain changes persisting in areas like the cerebellum and parietal cortex. The autonomic study we talked about showed a median symptom duration of 36 months, 3 years, strongly linked to ongoing functional disability. And those reviews I mentioned are now confirming that increased risk for new cognitive and other neurological conditions persists for at least 2 years.
So the picture is long-lasting impact for many.
It's becoming clear that for a significant subset of people, the neurological impact of COVID is proving to be very long-lasting, unfortunately.
We've talked mostly about adults, but the sources also discuss neurological PCS in children and adolescents. How does that picture look? It must be worrying for parents.
It's absolutely important to remember that pediatric populations are affected too, yes, which is particularly concerning because of the potential impact on their ongoing development and education.
Is there a specific definition for kids?
Yes, specific definitions for pediatric long COVID exist, like the WHO's, which also uses a 12-week time frame and impact on function as key criteria. Diagnosis can be challenging, especially in younger children who might struggle to articulate symptoms, and there's overlap with typical childhood illnesses.
Is it as common in kids as it seems to be in adults?
Prevalence estimates for long COVID in children vary widely across studies, maybe ranging from around 3.7% to 16.2%, or even higher in some cohorts. Generally, it seems less frequent than in adults, which may be partly because acute COVID infections in children are often milder.
But still a lot of kids affected globally.
Exactly. Given the large number of children infected globally, even a lower percentage translates to many affected kids.
What are the common symptoms in children, and are the risk factors similar to adults?
Risk factors are still being studied, but potential links include older pediatric age adolescents seems more affected than younger children, and initial severity of acute illness. Although importantly, just like in adults, it definitely occurs after mild or even asymptomatic infection in children too.
And the symptoms they experience.
Common symptoms are quite similar to adults. Fatigue is very common, reported in over 21% in some studies. Headaches. Significant cognitive dysfunction, that brain fog or difficulties with concentration, memory, and attention, are reported in around 27.7% experiencing neurocognitive issues. Sleep disturbances are common too, nearly 19%. Sensory issues, dizziness, and mood changes like anxiety and depression are also seen.
Does it look different in teens versus younger kids?
The pattern of symptoms might vary by age and sex. For example, neurological cognitive symptoms and fatigue might be more strongly linked to older age and female sex in adolescent cohorts, similar to adults. And the outcomes for kids. Do they recover faster?
While many children with persistent symptoms do gradually recover over time, a subset can have prolonged issues that significantly impact their ability to attend school, learn, and develop normally. Some initial data suggest that symptom prevalence might decrease significantly by around 6 months in adolescence, but the median duration of symptoms can still be substantial, ranging from 4 to 9 months, depending on factors like initial severity.
So still a long haul for some kids.
Definitely. This population needs age-appropriate assessment tools, tailored management strategies, and dedicated research specifically focused on the developing brain and long-term outcomes. We can't just extrapolate everything from adults.
Absolutely critical. This has been an incredibly comprehensive deep dive into the neurological complexities of long COVID. Let's try and bring it together now. Look at the big picture, the significant gaps that remain according to the sources, and what the priorities are for future research and action.
Okay.
So to recap, we've seen that neurological long COVID is a widespread, complex, and often persistent problem with a vast spectrum of symptoms affecting millions globally, even after mild acute illness.
Right.
The underlying causes are multifactorial and interconnected, involving neuroinflammation, autoimmunity, vascular damage, mitochondrial dysfunction, and potentially viral persistence.
Real mix.
Diagnosis is challenging because symptoms are subjective and fluctuating, and current standard objective tests often don't fully capture the patient's experience, making clinical history paramount.
Listen to the patient.
Exactly. Management currently relies heavily on multidisciplinary rehabilitation and symptomatic treatment because targeted therapies for the underlying mechanisms are still largely investigational.
Still searching for those cures.
The prognosis is variable, often chronic for a subset, with significant impact on quality of life and a concerning though not yet fully confirmed, potential for increased long-term neurodegenerative risk. And importantly, this affects children and adolescents too.
Given all that, what are the most critical unanswered questions? Where are the significant gaps in our understanding that the research needs to tackle?
The sources highlight many gaps. We still need to understand the precise links between specific underlying mechanisms and specific symptom clusters. Why does one person get mostly brain fog and another POTS? There's an urgent need for validated diagnostic criteria and objective biomarkers that can reliably identify and track the condition.
Better test.
Definitely. We lack clarity on the long-term trajectories beyond 2-3 years and predictors of who will recover versus who will develop chronic disabling symptoms. More research is needed on the impact in diverse populations, the influence of different viral variants, vaccination status, and crucially, reinfection.
Yeah, what does getting COVID again do?
Exactly. The fundamental biological basis for that disconnect between debilitating subjective brain fog and sometimes normal objective tests needs to be fully understood. And we need to clarify the specific mechanisms driving PCS after only mild or asymptomatic initial infection. How does it happen?
So what are the absolute top research priorities moving forward based on these sources?
The sources are very clear on several priorities. Standardization across research efforts is crucial, developing global definitions, diagnostic criteria for research, and standardized protocols for data collection so we can actually compare findings from different studies.
Apples to apples.
Right. In-depth mechanistic studies are vital to unravel the specific biological pathways involved, mapping the dynamics of viral persistence, autoimmunity, neuroinflammation, BBB breakdown, mitochondrial issues, and glial cell dysfunction in detail. Urgent priority is needed for biomarker discovery and validation, identifying reliable objective measures in blood, CSF, or imaging that can aid diagnosis, predict prognosis, and track treatment response. This requires large, well-designed longitudinal studies.
And trials for treatments.
Rigorous clinical trials are desperately needed. Well-powered, randomized controlled trials for promising pharmacological agents, standardized rehabilitation protocols tailored to specific symptom clusters like PM-aware rehab, and non-invasive stimulation techniques. Long-term longitudinal cohort studies are essential, following diverse groups of patients for 5 or more years, ideally longer, to understand the natural history, outcomes, and those long-term risks like neurodegeneration.
And kids.
Dedicated age-appropriate pediatric research is also a high priority. And ultimately, research should move towards developing personalized medicine approaches, trying to identify patient subgroups based on their biology who might benefit most from specific therapies.
And what are the implications for how healthcare systems and public health need to respond right now, given what we know?
They are significant and urgent. There's a critical need to raise awareness among all healthcare providers, patients, and the wider public that neurological long COVID is a real, prevalent, and potentially chronic condition that can affect anyone, even after mild acute illness. We need to combat disbelief and stigma.
Education is key.
Absolutely.
Right.
We need to develop and fund integrated multidisciplinary care pathways and specialized clinics to provide the comprehensive coordinated care required. Exploring the potential benefit of early intervention after acute COVID to prevent or mitigate PCS is important. We must ensure health equity and access to both care and participation in research, reaching underserved communities.
And prevention.
And crucially, public health strategies need to continue focusing on preventing acute infection through vaccination and other measures where appropriate, and planning for the substantial long-term healthcare and societal burden posed by a large population living with chronic disabling symptoms. We need to support these individuals.
This deep dive really puts into perspective just how widespread and profoundly complex the neurological effects of long COVID are. It's a lot.
It is.
We've seen the many ways scientists are grappling to understand why they happen and how challenging it is to pinpoint and treat this condition definitively right now.
It truly makes you pause and think about the incredibly intricate and sometimes fragile connections between our bodies and our brains, doesn't it?
Yeah.
And how an infection, even one that might have seemed like a mild illness at first, can initiate such persistent, multi-system, and long-lasting effects.
Building on this deep dive, thinking bigger picture, perhaps the unprecedented scale of this illness, the fact that so many people are affected and the research is so urgent, maybe this will actually force a paradigm shift. A shift in how medicine understands and approaches other complex chronic inflammatory and autoimmune conditions that affect both the brain and body. Maybe it will push research into new frontiers, generating insights and therapies that benefit not just long COVID patients, but potentially millions more living with other difficult-to-treat chronic illnesses like ME/CFS or fibromyalgia. It's a hopeful possibility stemming from a really challenging situation.
That's a very provocative thought indeed, and one that captures the potential broader impact of the intense research efforts being directed at long COVID right now. Let's hope so.
Thank you for joining us on this deep dive. We hope this has given you a much clearer understanding of the significant neurological complexities of post-COVID syndrome.
Thank you. It's a vital area that requires continued focus and empathy from all of us.
And thanks to you, the listener, for exploring these sources with us.
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.